Our next topic of discussion is going to be controlling for confounding in clinical research. So to start off, let's reintroduce the idea of a confounding variable. So remember that our goal is to understand this cause and effect relationship between our predictor and outcome. But sometimes there's going to be confounding variables which are going to be associated with both our predictor and both our outcome. So what this does is it makes understanding that predictor outcome relationship more difficult. So I think it's always good to have an example. So let's say we have an investigator who wants to study patients hospitalized with community-acquired pneumonia, and they want to improve how long these patients are hospitalized. So the standard community-acquired pneumonia patient will receive a beta-lactam antibiotic. And this investigator wants to see if adding a macrolide to that regimen will improve the recovery rate and improve how long these patients are hospitalized. So that's going to be our predictive variable. So we're going to be comparing patients who receive the beta-lactam alone to the patients who receive the beta-lactam and macrolide. And our outcome is going to be how long these patients are hospitalized. So we have our two study arms to compare, and we have our outcome. But how does severity of disease confound this relationship? Well, we can expect that a more severe patient is going to require more aggressive treatments. So are these patients recovering because of the treatments they received or the intervention that we assigned to them? So that's just an example of how it can confound our predictor variable. And then also these more severe patients, we can expect them to be hospitalized for longer. So now, because of this confounding effect, understanding this relationship is a lot more difficult. So what steps can we take to isolate that predictor outcome relationship and reduce that confounding effect? Well, that's going to occur. The methods for controlling for confounding are going to occur in the study methodology or design, or during the analytical phase of the study. So when we are designing our study, we can apply some type of methodology that can reduce confounding before we actually perform the study and collect the data. We can also control for confounding after we perform the study and collected the data. So that's kind of how these two methods kind of separate from one another. So this is kind of the clinical research process that we've seen throughout today. So we start with our target population, we extract our study population, and we perform our study, analyze the data, and produce new knowledge. So if we were going to apply some methodology to control for confounding, then it's going to occur at some point here while we are selecting our study population, and we're selecting it in a way that reduces the potential for confounding. So this is going to occur through experimental design and before we have actually collected any data. And the main methods here are randomization, restriction, and matching, and we'll discuss these in more detail. But just know that those occur during the study design. So let's say we could do our study, and then after we collect the data, we realize that there was a confounder that we didn't account for early on. So now we have data that we know is subject to confounding, so we need a way to reduce that confounding effect. Well, we do have ways to control for confounding while we're analyzing the data during the analytical phase. So the difference here is instead of knowing the confounders while we design the study, we identify them after we perform the study. So your main methods for controlling for confounding here are going to be stratification and by multivariable analysis. So if we were going to control for confounding through design, one powerful tool is randomization. In randomization, you can think of, we're going to randomly assign our intervention to our study subjects. And in theory, we're randomly assigning those confounders as well. So that's how it kind of reduces that confounding effect. But if you think back, Dr. Wild mentioned that randomization isn't practical in the observational setting. And Dr. Ramirez mentioned that observational studies are where a majority of clinical knowledge is produced and clinical practice is advanced. So when we're observing a cohort of patients, we can't really randomize anything to them because we don't have an intervention to randomize. We can still assess a predictor outcome relationship, but the groups are going to be pretty imbalanced because we didn't apply any randomization. It's not really ethical to assign risk factors. So basically, randomization is the gold standard for reducing confounding, but it's not very practical in every type of study design. So you can apply restriction to your sample. And essentially what this is, so let's say we have a sample and we know that age and gender are going to be confounding variables. So what we can do is select a sample where everyone is the same or similar age and the same gender. And that way we eliminate that confounding effect that we have from age and gender. So it's fairly straightforward. Then we can also apply some matching. And this is going to be commonly used in case control studies. So with matching, you are going to match on a set of pre-identified confounding variables. So let's say, once again, we know age and sex are going to be our confounding variables. So what we would do is we would take a subject in our intervention arm and match them to a subject in our control arm who is a similar age and gender. And then that way you have a balance between your two study groups. And just to reiterate, these are all applicable at the time of study design before we have done any data collection. So let's say we identify a confounder that we didn't address for in the study methodology. So how can we reduce that confounding effect? Well, the first method would be through stratification. And you can think of this as splitting your data into two different strata based on that confounding variable. So one strata will have that confounder, they will be patients with that confounder, and the other strata will be patients without that confounding variable. And what you do is once you stratify your data is you assess that predictor outcome relationship. And stratified analyses are useful when there's only one confounder that you're trying to control for, but once you introduce more confounding variables, they're not very suitable. And the reason is so let's say we identify a confounder and we stratify our data. And so we'll let this 2x2 table represent strata 1. So we have some exposure that we're trying to associate to some outcome. And this is strata 1 and this is strata 2. So we'll get into measures of association in the next presentation. But so we split our data and we are going to produce an odds ratio or a relative risk based off these two strata. If we have another confounding variable in addition to this, we would have to cut our data again. And it's just not feasible to keep separating our data into strata. So what we would do if we have multiple confounders is we would apply some type of multivariable analysis. And these are going to be useful when you are trying to reduce the effect of multiple confounders. And there's different types of multivariable analysis. Basically what it boils down to is applying some type of regression. So hopefully you're familiar with some of these types of regression. There's the multiple linear regression and the multiple logistic regression and a proportional hazards Cox regression. But depending on your study, not all of these types of regressions are going to be useful. So how do we know which multivariable analysis is going to be appropriate for our study data? Well, that comes down to the outcome that you're looking at. So if you're looking at a continuous outcome, so let's say we're looking at a change in weight or something that's measured on a continuous scale that can accept any value between infinity and negative infinity, well, then you're going to want to use a multiple linear regression to adjust for that confounding effect. So if we're looking at a dichotomous outcome, such as mortality or recovery, where at the end of the study, either the patients experienced it or not, then you can use a logistic regression to control for those confounding variables. And we can also, if you're looking at a time to event analysis, so if you're looking at not just if a patient experienced mortality, but the time to that actual event, you can apply a proportional hazards regression because those are suitable for handling those time to event outcomes. And with that, I'm going to hand it back off to Stephen so we can go over some measures of association.